Hello. Today we will be covering alterations in sensory input, specifically neurologic, and alterations in regulation function, specifically endocrine. Chapter 27, meningitis. This is an inflammation of the meninges. The three main types are bacterial, non-bacterial or aseptic, and tuberculosis. Strep pneumonia is probably the most common cause of meningitis in children 3 months to 11 years of age. Vaccines have dramatically decreased the number of cases of meningitis. We can prevent meningitis with the vaccines HIB and pneumococcal starting at 2 months of age, and then meningococcal polysaccharide is given between 11 to 12 years of age, and a booster may be given at 16 years of age. So signs and symptoms, often these are divided by age. Children and adolescents, here you're going to see typically an unusually abrupt onset of fever, chills, headache, vomiting, alterations in sensorium. Seizures are often the initial sign, irritability, agitation. They may develop photophobia, delirium, hallucinations, aggressive behavior, drowsiness, stupor, and coma. Nuchal rigidity, which is just a fancy way of saying a stiff neck, may progress to opisthotonous, and this is where the head is significantly extended, and even the back and spine might be seriously extended like this. A positive Kernick sign, and this is when the patient is supine and the leg is bent at a 90 degrees, and then when you straighten it, they complain of pain. Also, they would have a positive Brudzinski sign, and this is when you bend the head forward, so the chin is to the chest, the leg will automatically flex forward towards the abdomen. Hyperactive but variable reflex responses will take place. Signs and symptoms can also be specific to the type of organism. Infants and young children, the classic picture, which we've sort of presented above, really is rarely seen in children between 3 months and 2 years of age. Here they can have fever or hypothermia, poor feeding, vomiting, marked irritability, frequent seizures, and often they can have a high-pitched cry with that. Bulging fontanelles, nuchal rigidity may or may not be present, and typically Brudzinski's and Kernick sign are not helpful in diagnosis for children in this age group, because it's really difficult to elicit and evaluate in children of this age group. Rocking or cuddling actually will irritate this child. That's something that is unique in meningitis to the infant and young children. So if they have meningeal irritation, they do not want to be rocked or cuddled. Neonates specific signs here. The child, it looks well at birth, but then within a few days, they begin to look and behave poorly. They refuse feedings. They may have a poor sucking ability, vomiting or diarrhea, poor tone, a lack of movement, a weak cry. Full tense and bulging fontanelles may actually appear late in the course of illness. The neck is usually supple. So remember with the other groups, we talked about that stiff neck. That's not something that we often see, or we will see here. So a nursing alert, if you see a petechial or purpuric rash, this child requires immediate emergency attention because it can be meningococcemia, which has a 90% mortality rate. So diagnosis. CBC, complete metabolic panel, blood cultures, sometimes nasal and throat cultures. A lumbar puncture is the definitive diagnosis. In the cerebral spinal fluid, we will see elevated white blood cell count, elevated protein, elevated pressure, and a decrease in the glucose and a positive culture. The color is typically turbid or cloudy. Serum glucose is typically done a half hour before the lumbar puncture. So when we do a lumbar puncture, we want the child in a fetal position so the head is down and the knees are to the chest. This can be done side lying, or you can actually even have the small neonate positioned sitting, and they can be held in a fetal position with their shoulders and their head towards their knees. If time permits, LMX, which is the 4% lidocaine, or EMLA cream, can be applied. These are both topical anesthetics, and you want to apply these to the skin in the area of L3 to L5, because this is typically where they're going to do the lumbar puncture, and this will help to reduce the pain associated with the lumbar puncture. For maximum effect, if they are using EMLA cream, you want to apply that for an hour, or if they are using LMX cream, this should be applied for 30 minutes prior to the procedure. What is the treatment? Large doses of IV antibiotics, such as ampicillin, cefotaxime, ceftriaxone, can be used if they are over 6. Also penicillin G, and they are given until the cerebrospinal fluid has a negative culture and the glucose is normal. Some complications of meningitis include, and this is the bacterial meningitis, includes ADHD, deafness, blindness, cognitive impairment, cerebral palsy, muscle weakness, seizures, septic arthritis, septicemia, subdural effusions, SIADH, DIC, and hydrocephalus. Nursing, droplet isolation during diagnosis and at least 24 hours after starting antibiotic therapy. You want to refer to the hospital's specific policies regarding this. Keep them in a dark, quiet room. They don't like the light, and they also don't like a lot of noise because they tend to be very sensitive to this. Assess the vital signs, assess the neurological status, strict intake and output. They will be on IV fluids, and they may have seizures, so please make sure that we are maintaining seizure precautions for their safety. Monitor for increased intracranial pressure. Typically, we will measure the head circumference at least daily. Acetaminophen for temperature control. Also, this can be used for any kind of headaches and pain. If they are not vomiting, they would be on a high protein, high calorie diet. Typically, they'll have small, frequent meals. If they have opisthotonus, you want to place them on their side. If they have a decrease in their level of consciousness, obviously they're going to be NPO, because we don't feed people that have a decreased level of consciousness, orally at least. So discharge, basically you want to identify any complications early and then treat them. Again, as I mentioned before, this can be prevented with the vaccines. Non-bacterial meningitis. This is most often caused by enterovirus. The signs and symptoms, they may be abrupt or gradual, and many of the presenting signs and symptoms are the same as for bacterial meningitis, which include the headache, fever, photophobia, stiff neck, malaise, and then in 1 to 2 days, signs of meningeal irritation, abdominal pain, nausea, vomiting, and a maculopapular rash may develop. These signs and symptoms subside in 3 to 10 days, and the child has no long-term complications. The diagnosis, again, is that lumbar puncture, but the cerebral spinal fluid looks a little bit different. So here, you're going to see slightly elevated white blood cells, normal glucose, negative culture, and then the protein may be normal or slightly elevated, and the color is typically clear or just very slightly cloudy. The treatment is actually the same as bacterial meningitis, so the antibiotics and isolation. until it is confirmed that it is viral. Then we are just going to treat the symptoms that the patient is exhibiting. So it's really just palliative treatment after that. Next, we're going to talk about seizure disorders. And here, these are transient occurrences of signs and or symptoms due to abnormal, excessive, and synchronous neuronal activity in the brain, which cause changes in the level of consciousness. It can also cause involuntary muscle movements, altered behavior, and sensory signs and symptoms. Epilepsy is 2 or more unprovoked seizures more than 24 hours apart, and these can be caused by many different problems. So some pathophysiology, there really are many etiologies of seizures, but regardless of the etiologic factor or the type of seizure, the basic mechanism is the same. They have abnormal electrical discharges. They may arise from the central areas in the brain that affect consciousness, or they may be restricted to one area of the cerebral cortex, and then this can produce manifestations characteristic of that particular area of the brain, or they may begin in a localized area of the cortex and then spread to other portions of the brain. And if sufficiently extensive, this can then actually produce a generalized seizure activity. So pre-seizure, they may have an aura. So this is a smell or a visual or just some kind of sensation. It's kind of like a warning where the person feels like they're going to have a seizure, and they can say, I feel like I'm going to have a seizure if they are verbal. Classically, we see these in focal seizures with impaired awareness. Ictal is the time during the seizures. When people have seizures, typically we want to time it when it begins and when it stops. And then post-ictal, this is the time after the seizure. And here we want to see how the child is doing after the seizure and what is their level of consciousness, and any other signs and symptoms after the seizure. So there's a few different categories of seizures. One is called focal seizures, and this used to be called partial seizures. And you're going to notice in your textbook that they sort of interchangeably use the terms partial seizures as well as focal seizures. So focal seizures without impaired awareness, so these were formerly called simple partial seizures. Here you're going to see sensory symptoms that occur in one part of the brain and cause no alterations of consciousness, and this is referred to as an aura, and this is sometimes accompanied by motor movements. Focal seizures with impaired awareness, so this is formerly called complex partial seizures. This is sensory and or motor symptoms that result in a change or loss of consciousness. And then they have focal to bilateral tonic-clonic seizures. This is formally simple or complex seizures, secondarily generalized. So this is where you can have a focal seizure with or without awareness that evolves into a generalized seizure, which is typically a tonic-clonic seizure. The second big category are your generalized seizures. And here we have tonic-clonic. They used to be called grand mal. That's a very old term, but you might still hear that. Next, you have absence seizures. Another old term for that is petit mal. Another type is atonic or drop attacks, myoclonic seizures, infantile spasms, and febrile seizures. So the classifications and clinical manifestations of seizures, here we're going to see them based on their different categories. And this is where your textbook sort of goes back to talking about the seizures in terms of being partial seizures. So here, simple partial seizures with motor signs. These are characterized by localized motor symptoms somatosensory, psychic, autonomic symptoms, or a combination of these. And the discharges are abnormal discharges that are unilateral, so they stay on one side of the brain typically. Some things that you could see are aversion seizures, and this is the most common motor seizure that we see in children in this category. So the eyes or the eyes and head will turn away from the site of the focus. There may be an awareness of the movement or a loss of consciousness. They can have it's called a Rolandic or Sylvan seizure, and this is tonic-clonic movements involving the face, salivation, arrested speech. This does most commonly occur during sleep. They also can have something called a Jacksonian march, which is rare in children, but this is an orderly sequential progression of clonic movements beginning in a foot, hand, or face, and then they move or they march to the adjacent body part. Simple partial seizures with sensory signs. These are characterized by sensations including numbness, tingling, prickling, paresthesias, or pain originating in one area like the face or the extremities and spreading to other parts of the body. Visual sensations or formed images, motor phenomena such as posturing or hypertonia. This is uncommon in children under 8 years of age. Focal seizures with impaired awareness. So these are observed more often in children from 3 years old through adolescence. And these are characterized by periods of altered behavior, amnesia for the event, so they don't remember it, an inability to respond to the environment, impaired consciousness during the event, drowsiness or sleep usually follows the seizure. Confusion and amnesia may be prolonged. That complex sensory phenomena or aura is not uncommon for this to be present with this type of seizure. And the things that you might see here is they have that strange feeling in the pit of the stomach. It can rise towards their throat. They can have unpleasant odors or taste. They can have just like sort of a strange feeling. Like I say, they may have also feelings of fear and anxiety because they have this sensation, they know they're going to have a seizure. Children may actually emit a cry or try to get help. Some patterns of motor behavior include stereotypic, similar with each subsequent seizure. They may suddenly cease activity. They might look dazed. They may stare into the space and become confused and apathetic. They might become limp or stiff or display some form of posturing. Again, they might be confused. They can perform purposeless, complicated activities in a repetitive manner. And basically that's also called automatism. And examples of these would be like walking, running, kicking, laughing, also speaking incoherently. And then this kind of seizure is followed typically by post-ictal confusion or sleep. Other things that you could see with this would be oropharyngeal activities like lip smacking, chewing, drooling, swallowing, and nausea or abdominal pain followed by stiffness, a fall, and post-ictal sleep. These rarely manifest as rage or temper tantrums. And aggressive acts, though, are uncommon during this seizure. Generalized seizures. So tonic-clonic, this is the most common and most dramatic of all seizure manifestations. It occurs without warning. The tonic phase lasts approximately 10 to 20 seconds. Signs and symptoms, the eyes roll upward. There's an immediate loss of consciousness. If they are standing, they will fall to the floor or ground. Stiffens in a generalized symmetric tonic contraction of the entire body musculature. So arms usually flexed. The legs, head, and neck typically extend. They may actually have like a piercing cry prior to or as it's just beginning to start. They may be apneic, they may become cyanotic. You might notice an increase in salivation and a loss of the swallowing reflex. The clonic phase, this lasts about 30 seconds, but this can vary from only a few seconds to a half hour or longer. So obviously the longer that occurs, that's much more concerning. Signs and symptoms, violent jerking movements as the trunk and extremities undergo rhythmic contraction and relaxation. They may foam at the mouth. They may be incontinent of urine and feces. And as the event ends, know that the movements will become less intense, or they occur at longer intervals, and then they will stop entirely. So status epilepticus, we're going to talk about this in a little bit. This is a series of seizures at intervals that are too brief to allow the child to regain consciousness between the time of one event and then when the next one begins, or seizures that are lasting longer than 30 minutes. This requires emergency intervention, typically IV Ativan or diazepam. This can lead to exhaustion, respiratory failure, and death. It has been suggested that a term impending status epilepticus be used for a continuous or series of seizures lasting between 5 and 30 minutes. So post-ictal state, here they appear relaxed. They may remain semi-conscious and difficult to arouse. They may awaken in a few minutes. They may be confused for a few hours. They may have poor coordination, mild impairment of fine motor movements. They may have visual and speech difficulties. They may vomit or complain of severe headache. They may be, really, we don't want to leave these kids alone. Note that they might sleep for several hours, and then if they're sleeping, then you can let them just rest independently. When they awake, they will be fully conscious. They usually will feel tired. They might complain of sore muscles and a headache, but they do not recollect the entire event. So once the seizure is occurring, they don't remember anything. Absence seizures. Here, the onset is usually between 4 and 12 years of age, more common in girls than in boys. And this usually stops at puberty. Here, this is really just like a brief loss of consciousness. There's minimal or no alteration in muscle tone. These can actually go unrecognized because there may be just little changes in the child's behavior. They can have an abrupt onset, and they can develop suddenly 20 or more attacks daily. And often these are mistaken for inattentiveness or daydreaming. Events can be precipitated by hyperventilation, hypoglycemia, stresses like emotional and or physiologic stresses, fatigue, or sleeplessness. So the signs and symptoms are really just a very brief loss of consciousness. They can appear without warning or aura, usually lasts about 5 to 10 seconds. They may have a slight loss of muscle tone. So the child may, if they're holding something, they may drop the object, but they typically can maintain their own postural control. So they generally don't fall. Minor movements such as lip smacking, twitching of the eyelids or face, or slight hand movements not accompanied by incontinence may occur. Typically there is an amnesia for the event, so they don't remember what happened during that period of time. They may need to reorient themselves to what they were doing previously. Atonic or akinetic seizures, these are also called drop attacks. This is typically seen between 2 and 5 years of age. It's a sudden momentary loss of muscle tone and postural control. The events reoccur frequently during the day, particularly in the morning hours and shortly after awakening. So signs and symptoms. Here you're just going to see a complete loss of tone, and this causes the child to violently fall to the floor, and they're unable to break the fall by putting their hands out. So then they can actually be seriously injured by these. They have a loss of consciousness, typically momentarily. Myoclonic seizures. Here, this is a variety of seizure episodes. They may be isolated as a benign essential myoclonus. They may occur in association with other seizure forms. So these are characterized by sudden brief contractures of a muscle or group of muscles. They can occur singularly or repetitively. There is typically no post-istal state. They may or may not be symmetric, and they may or may not have a full loss of consciousness. Infantile spasms, these are also called West syndrome, and these are massive spasms, hyperarrhythmias, Salem episodes, or infantile myoclonic spasms. These typically occur within the first 4 to 8 months of life, or during the first 4 to 8 months of life, twice as common in males as in females. The child may have numerous seizures during the day without postictal drowsiness or sleep. Sadly, the outlook for normal intelligence in these children is just really poor. Signs and symptoms, they can have a possible series of sudden, brief, symmetric muscular contractions. The head will flex, the arms may extend, and the legs may dry up. Eyes may roll upward or inward. They may be preceded or followed by a cry or a giggling. There may or may not be a loss of consciousness. Sometimes they may have a flushing or pallor or cyanosis. Infants who are able to sit but not stand, they can have a sudden dropping forward of the head and neck with the trunk flexed forward and the knees drawing up. And this is called that Salem or jackknife seizure. Lennox-Gastaut syndrome. This is between 20 and 50% of infants who have infantile spasms. Eventually, they will develop this. And this is diagnosed on 3 criteria: the presence of multiple seizure types like atonic, myoclonic, tonic, and atypical absence. 2, intellectual disability. And 3, a slow spike wave discharges on EEG. The onset of Lennox-Gastaut syndrome is between 1 and 8 years of age. Children with this typically have multiple seizures daily. Tonic seizures are the most common. So diagnosis, here we're going to look at history and physical. You want to question anybody who witnessed the seizure. Ask them if they were able to find out, was there an aura present? Did they hear a scream? Was there a loss of consciousness? What was the length of time? We do want to do lots of different kinds of diagnostic tests like a CBC, a metabolic panel, a CT, an MRI. If they are on anti-seizure medications, it's important to check the levels, right? Because as children grow, their levels, their medication may change because obviously their weight is going to change. So it is important to check their levels. Lumbar puncture, again, we're looking for any kind of illness. And then an EEG, this is actually the most helpful in diagnosing where the seizure originated. EEGs can be done while the child is awake, asleep, I'm sorry, not asleep. They can be done, well, yeah, they can be done while they're asleep. Sleep deprived, they can be done with flashing lights, noise, and hyperventilation. So assessment questions. We want to ask about family history of seizures, pregnancy history, birth history. Did the child complain of not feeling well or feeling funny just before the seizure? Again, assessing for illness, or did they have an aura? Did the child complain of a headache, nausea, muscle pain, or vomiting? Did they suffer any kind of trauma prior to the seizure? Did they get into any medications or poisons prior to the seizure? Are the movements on just one side of the body? Did they injure themselves during the seizure? Did they have any kind of color changes during the seizure? So did they become pale or cyanotic? Did they lose consciousness? Were they sick or febrile? Were the movements tonic-clonic? Was the child's vision normal? Were the pupils dilated or the eyes deviate to one side? Were they incontinent? Again, how long did it last? How long did it take for the child to wake up? Was the child lethargic, weak, or uncoordinated upon arousal? So there's lots of things that we're going to be asking. Treatment. So if it's a febrile seizure, they may actually give them anti-seizure medications just until the fever is gone. Otherwise, anticonvulsants, a ketogenic diet, which is a high-fat and very, very low-carb and adequate protein diet, can be used to treat seizures. Vagus nerve stimulator for children who are poorly controlled on drugs. It can also be used as an adjunctive treatment. Surgery may be necessary to remove a lesion or a part of the brain where the seizure originates if they're having just significantly intractable seizures. So in general, anticonvulsants really are the big treatment for people that have seizures. And we really try to make it so they are on just one medication. That is ideal, but sometimes they may have to be on a second medication as well as some additional therapies like that ketogenic diet or the vagal nerve stimulation to help get some control of their seizures. The medications commonly used, so for the partial or tonic-clonic, typically can be Tegretol, Dilantin, Cerebix, valproic acid. The drug of choice for absence seizures is your Zerontin and valproic acid. Children taking phenobarbital or phenytoin, also called your Dilantin, need to receive adequate amounts of vitamin D and folic acid. Dilantin and phenobarbital should not be taken with milk. Phenytoin, Dilantin, can be given through an IV, but it can only be mixed with normal saline, and it can only be given up to 50 milligrams per minute. So that's the reason we are more leaning to using phosphenotoin or Cerebix. This can be given 3 times faster than IV phenytoin, and this also may be mixed with normal saline or a dextrose solution. Prophylactic administration of calcium and vitamin D supplements is also recommended for all patients receiving anti-epileptic medications. And then it's also important to do bone mineral density testing for patients on long-term anti-epileptic medications. So as a nurse, we want to maintain a patent airway. Obviously, don't put anything in the child's mouth. They may require oxygen if their oxygen saturation is less than 95%. Check the vital signs, and absolutely please make sure that you place the child on their side. This helps to prevent any aspiration. So safety, if they have frequent seizures, they may be required to wear a helmet. We want to pad the side rails, do not restrict the movement, protect the head, especially from injuries. Having them wear a medic alert bracelet, you want to have them lay on their side and place on an incontinent bed pad routinely on the bed. Make sure that we are giving them meds per the doctor's order and monitor the levels. As I mentioned earlier, the doses need to be adjusted as the child grows. The family needs a lot of emotional support because this can be a very scary event for both the parent and the child. You want to encourage both of them to verbalize their fears and anxieties. We want to reinforce the medication regime and side effects, determine if a school nurse needs to give medications. We need to do labs and follow-up appointments. Dental visits are going to be very important because phenytoin or Dilantin can cause gingival hyperplasia. So it's very important that they brush and floss their teeth after each meal. You want to use a soft toothbrush. anti-epileptic medications can typically be stopped, and they do a very slow tapering process when the child has been seizure-free for at least 2 years and they have a normal EEG. The drugs are gradually reduced over a couple of week period. Repeat EEGs are obtained every 6 months to 2 years after. In general, driving can reoccur. It's really dependent on the state. So if a child is seizure free, I believe in the state of California, it is 3 months, but it depends on state law. So I will not ask specifically for a time frame, but know that if a child is seizure free for a specific period of time, depending on state law, they may be able to drive. They really should avoid contact sports because obviously if they were to have a seizure, you don't want somebody getting hit on a football field. They should swim with a companion, have supervision when using a dangerous machinery, and they shouldn't be using dangerous machinery if they are having significant problems with uncontrolled seizures. Family members should know CPR. If they have a vagal nerve stimulator, the families need to know how to use that and when to use that. And if they are being given rectal diastat, the teachers and the caregivers should be aware how to use it. So emergency treatment. So this is for your tonic-clonic seizure. And quite frankly, I would say this is just good information in general related to seizures. So please remain calm. I know it's scary, but you want to remain calm. Time the seizure episode. If the child is standing or seated, ease them to the floor. Place a pillow or folded blanket or just something soft under the child's head, because obviously we want to protect their head. And make sure that when you're laying them down, you've positioned them on their side. Loosen restrictive clothing. If they have glasses on, take them off. Clear the area of any hazards or hard objects. Allow the seizure to end without interference. So please do not hold them down. That is not necessary. And here they're saying if vomiting occurs, turn the child to one side. You want to actually put them on their side, even if they don't vomit, because they can have secretions and they can aspirate those. So do not attempt to restrain the child or use force. Don't put anything in the child's mouth, and don't give them any kind of foods or fluids. After the seizure, you want to time the postictal period, check for breathing, check for the position of the head and tongue, reposition if the head is extended. If breathing is not present, obviously we're going to give rescue breathing and call EMS. Keep the child on their side. Stay with the child. Do not give food or fluids on the child until the child is fully alert and the swallowing reflex has returned. Look for medical identification and determine what factors occurred before the onset of the seizure that may have been triggering factors for the seizure to occur. Assess the head and the body for injuries. Check inside the mouth to see if the tongue or the lips have been bitten. Somebody with a focal seizure with impaired consciousness, what are we going to do the seizure here? Do not restrain the child's movements. Remove harmful objects from the area. Redirect to a safe area. Do not agitate them. Instead, talk in a calm, reassuring manner. Do not expect the child to follow instructions. Remember, they're not really conscious. And then watch to see if the seizure progresses to a generalized seizure, because that can occur. After the seizure, stay with the child and reassure until they are fully conscious. When do we need to call the EMS? If the child stops breathing. Is there evidence of injury or the child is diabetic or pregnant? Seizures last for more than 5 minutes unless the seizure for that child typically last longer than 5 minutes, and a written medical order is present. So if a doctor tells you how long to, when you need to call EMS, then you would follow that specific order. If status epilepticus occurs, if the pupils are not equal after the seizure, if the child is vomiting continuously 30 minutes after the seizure has ended, because this can be a sign of another acute problem. If the child cannot be awakened and is unresponsive to pain after the seizure has ended, if the seizure has occurred in water, obviously because they could have aspirated some of the water. And then again, if this is a first seizure. So there are some rectal anti-epileptic medications that can be used. Really, rectal preparations of some of the anti-epileptic medications are highly effective when a child is unable to take oral medications because of repeated vomiting, gastrointestinal surgery, or status epilepticus. Parents can learn to administer rectal anti-epileptic medications for home treatment. Rectal diazepam is a useful adjunctive home treatment for children at risk for prolonged seizures or clusters of seizures. It also minimizes hospitalization and enhances parental confidence. Buccal or intranasal midazolam and rectal diazepam are simple, effective, and safe treatments for home or pre-hospital management of prolonged seizures and impending status epilepticus. Time to cessation of the seizure with midazolam was 4 minutes shorter than with rectal diazepam. Respiratory depression is a potential side effect of these medications when more than 2 doses are given. However, respiratory depression is not a side effect of rectal diazepam when it is administered as recommended. Intranasal midazolam is safe and effective for stopping seizures, and is also easier to administer than rectal diazepam. So the term of impending status epilepticus is used for a continuous seizure or seizures of series of seizures lasting between 5 and 30 minutes with the designation that treatment should begin within 5 minutes. Status epilepticus is seizures lasting more than 30 minutes or a series of seizures in which the patient does not regain a premorbid level of consciousness. So, therapeutic management. We need to maintain a patent airway, monitor for apnea, make sure the patient is safe, make sure they have IV access. Medications, typically initially it will be IV diazepam or lorazepam. Phosphonatoin may be used followed by phenobarbital. We want to support the family because again, this is very scary. Typically when they're in the hospital, IV diazepam or lorazepam is that first line of drug. Lorazepam does have a rapid onset, 2 to 5 minutes, and a long half-life, 12 to 24 hours. We need to monitor the vital signs and for respiratory depression. When benzodiazepines are ineffective, which is your diazepam or lorazepam, phosphonatoin followed by phenobarbital may be used. And then here these children are at a high risk for apnea and may require respiratory support. If they continue to have a seizure, then general anesthesia, continuous infusion of midazolam, propofol, or pentobarbital may be required. And then these children may need to be intubated. And they may even be doing more like continuous EEGs. Nursing care, obviously, always ABCs, life support, monitor the blood pressure. We're going to monitor all the vital signs, but it's important to monitor the blood pressure because hypertension can actually occur during the first 30 to 45 minutes. Typically, it'll return to normal, but it may end up decreased due to the medication, as well as monitoring the body temperature because hyperthermia can result since they have an increase in motor activity. Febrile seizures, this is 6 months to 5 years of age. They are generalized, lasting typically less than 5 minutes. Typically, the fever is 101.4 or over. The seizure occurs as the temperature is increasing versus a prolonged elevation. They're usually benign, which is a great thing. 95% never have epilepsy or neurological damage. If the seizure lasts more than 5 minutes, take the child to the emergency room. Most febrile seizures have stopped by the time the child is taken to a medical facility and require no treatment. Seizure precautions. The extent of precautions really depend on the type, severity, and frequency of seizures. Precautions may include side rails being raised when the child is sleeping or resting. And this is, of course, they are going to be up when the child is in the hospital, but they may want to have some kind of side rails when the child is at home. Side rails and other hard objects are padded. A waterproof mattress or pad on a bed or crib. Other appropriate precautions during potentially hazardous activities may include swimming with a companion, showers instead of tub baths. And if they're going to do a tub bath, then they need to have close supervision. Use of protective helmets and padding during bicycle riding, skateboarding, and skating. If they have frequent seizures, they just may need to wear a helmet in general. Supervision during use of hazardous machinery or equipment. Have the child carry or wear a medical identification. So this is where that medical bracelet is very beneficial. Also alert other caregivers to the need for any special precautions, and even letting the school know as well. As I mentioned earlier, the child may not drive or operate hazardous machinery or equipment unless they have been seizure-free for a designated period of time, and this does vary by state. An early sign of neurologic dysfunction is a decreased level of consciousness. Using the AVPU method is an accurate assessment method used for children. So what this is we are assessing, are they awake? Are they verbal? Do they only respond to painful stimuli, or are they unresponsive? So again, are they just spontaneously awake? Or do they only respond to verbal stimuli? Or are they only responsive to painful stimuli, or are they fully unresponsive? Again, we talked a little bit about Reye's syndrome when we discussed infectious diseases, so I'm not going to go over that again, but please, you need to know Reye's syndrome for the test. Next, we're going to talk about hydrocephalus, and this is a disturbance in the balance of CSF. So there can be an impaired absorption of CSF within the arachnoid spaces. The ventricles communicate, so there is a non-obstructive or communicating hydrocephalus, or there is an obstruction to the flow of the CSF within the ventricles. So the ventricles do not communicate, so there would be an obstructive or non-communicating hydrocephalus. Again, so signs and symptoms, infancy. So early infancy, you would see abnormally rapid head growth, bulging fontanelles, especially that interior fontanelle, sometimes even without head enlargement. You can see tense, non-pustule, dilated scalp veins, separated sutures, Macewen sign, which is a cracked pot sound on percussion of the head, and then thinning of the skull bones. In later infancy, you can see frontal enlargement or bossing of the head, depressed eyes, setting sun sign, and this is where the sclera is visible above the iris. The pupils may be sluggish with unequal response to light. Infancy in general, they may be irritable, lethargic. The infant cries when they are picked up or rocked, and they quiet when they are allowed to lie still. The early infantile reflexes may actually just persist. Normally expected responses fail to appear. They may display changes in their level of consciousness. They may have extreme opisthoughtness. The lower extremity spasticity may occur. They may have vomiting. Advanced cases, they may have difficulty in sucking and feeding. They may have a shrill, brief, high-pitched cry, and then they can also have cardiopulmonary issues. Headache. Childhood, here they can have headache on awakening. This may get better after they have an emesis or an upright posture. They can have papilledema, strabismus, and extrapyramidal tract signs like ataxia. They can also have irritability, lethargy, apathy, confusion, incoherence, and again, vomiting. Diagnosis, this is based on history and physical, daily head circumference measurements. Know that head circumference measurements that cross 1 or more percentile lines within 2 to 4 weeks and neurological signs that are progressive can indicate this. A CT scan can show dilated ventricles, and then if there is dye injection, the cerebrospinal fluid flow course can also be seen. And an MRI may also be done. Treatment. So if there is a blockage, they would remove the blockage through surgery. If that's not possible, then they can divert the excess cerebrospinal fluid with a shunt. Ventriculoperitoneal shunts are most common. So VP shunts are usually replaced 2 to 4 times as the child grows. Common shunt problems include infection or malfunction, and the type of malfunction would be a blockage, kinking, or valve breakdown. Signs and symptoms of this would include increased intracranial pressure, such as nausea, vomiting, irritability, and a bulging fontanelle. These are frequently accompanied by worsening neurological status. Early signs of shunt failure are headache and decreased appetite. The most serious problem in shunt, in VP shunts is shunt infection. And it is it most commonly occurs in the first month of placement of the shunt. So signs and symptoms include ventriculitis, meningitis, low-grade fever, malaise, headache, nausea, and vomiting. So how do we treat that? IV antibiotics for 7 to 10 days. Typically, they are very high-dose antibiotics. They may need to remove the shunt and use an external drainage device until the infection is gone. And then they may need to replace the shunt. As a nurse, again, checking that head circumference daily, checking for signs and symptoms of VP shunt malfunction, monitoring for signs and symptoms of infection. If the child has a shunt placed or a new shunt is placed, keep the child flat after the VP shunt is placed because we don't want to prevent rapid drainage of the CSF fluid. This will prevent a subdural hematoma. Gradually, you will be elevating the head of the bed per the doctor's orders, monitoring the vital signs at least every 2 to 4 hours, and please do not position the head on the shunt. Arbitrary pumping of the shunt may cause obstruction and other problems and should only be done under the direction of the neurosurgeon. Typically, they are NPO 1 to 2 days. If bowel sounds are present, they may have be fed, and you want to feed them small, frequent meals because they are more prone to vomiting. We also want to observe for signs and symptoms of abdominal distension and constipation because the cerebral spinal fluid is being diverted to the peritoneal area. And so this can cause issues with peritonitis and post-operative ileus. So we do want to monitor for that. Nursing alert. So tablet computers such as iPads and magnetic toys may interfere with magnetically programmable shunt valve settings, and they should be kept at least 2.5 centimeters from the shunt's valve. Family support. They need to make sure that they know the signs and symptoms of shunt malfunction. Contact sports should be avoided. Helmets should be worn if they are skating, skiing, biking, and skateboarding. And also the families can be referred to community services such as the National Hydrocephalus Foundation and Hydrocephalus Association. Lastly, we're going to talk about alterations in regulation function, specifically endocrine. And here we're only going to talk about two problems. One is diabetes mellitus, and the second is precocious puberty. This is in chapter 28. So first, diabetes mellitus. This is a chronic disorder of metabolism characterized by hyperglycemia and insulin resistance. This is characterized by a total or partial deficiency of the hormone insulin. This is the most common endocrine disorder of childhood. The peak incidence is in early adolescence between 10 and 15 years of age. This is diagnosed based on any of the following 4 abnormal glucose metabolites. One is an 8-hour fasting blood glucose level of 126 milligrams per deciliter or more. 2, a random blood glucose value of 200 milligrams per deciliter or more, accompanied by classic signs of hyperglycemia. An oral glucose tolerance test finding of 200 milligrams per deciliter or more in the 2-hour sample. And a hemoglobin A1C of 6.5 or more. So the two major groups, you've got type 1, and this is characterized by a destruction of the beta cells, usually leading to an absolute insulin deficiency. Most cases of diabetes mellitus of childhood are type 1. This was previously called juvenile diabetes. And as I mentioned before, this is the most common cause of diabetes in children, type 1 diabetes. This is commonly, I already talked about when it was commonly diagnosed, but please note that this can also occur at any age from infancy to age 30. So type 1, it is believed to be an autoimmune disease arising when a person with a genetic predisposition is exposed to a precipitating event, such as a viral infection. Heredity is a prominent factor in the etiology. So signs and symptoms in general, we've got the 3 Ps, and these are polyuria, polydipsia, and polyphagia, weakness, fatigue, headache, nausea, vomiting, abdominal cramps, glycosuria, ketonuria, and dried, flushed skin. Type 2. This type of diabetes arises because of insulin resistance. The onset here is usually after age 45, but because of the obesity issue in children, we are seeing this sometimes. Native American, Hispanic, and African American children are at increased risk of type 2 diabetes. These people who are affected may or may not require insulin injections. And as I mentioned, this is typically seen in obese and overweight children who are physically inactive. This occurs as a result of insulin resistance plus some insulin deficiency. Insulin resistance results in diminished liver, muscle, and adipose tissue sensitivity to insulin. So here we can see acanthosis nigricans, which is a thickening and hyperpigmentation of the skin at the neck and flexural areas of the body. We can also see hypertension, hyperlipidemia, and sleep apnea. So blood glucose levels at or above 200 milligrams per deciliter without fasting is diagnostic in type 2 diabetes. So what are some of the issues with that type 1? So no insulin is produced and the cells cannot use glucose. So excess glucose in the blood spills into the urine. This is increased in blood glucose can act as an osmotic diuretic, resulting in dehydration, hypotension, and renal shutdown. Without glucose, Cells are starving, resulting in signals of hunger and increased food intake. So we've got that polyphagia. The body is attempting to compensate for lost energy by converting triglycerides into fatty acids, which then form ketones, which results in that metabolic acidosis. So here's just a little picture of the polyuria, polydipsia, polyphagia, and involuntary weight loss. So ketoacidosis, this is when the glucose is unavailable for cellular metabolism. The body is breaking down alternate sources of energy. So here you're going to see in diabetic ketoacidosis, ketones and glucose in the urine, and then you can also see dehydration. So when the ketones are released and excess ketones are eliminated in the urine, you're going to see ketonuria. Or you can also see this is trying to be excreted by the lungs, and you can have that fruity acetone breath. Ketones in the blood are strong acids, and they can actually lower the serum pH and produce that ketoacidosis. Kussmaul respirations, this is a hyperventilation characteristic of metabolic acidosis. And basically, this is because the respiratory system is trying to eliminate excess CO2 by increasing the depth and rate of respirations. Diabetic ketoacidosis, this is a pediatric emergency, and this is a state of relative insulin insufficiency and may include the presence of hyperglycemia, so typically a blood glucose level of 200 or more milligrams per deciliter. Ketonemia is strongly positive, so you might see an acidosis of a pH of less than 7.3 and a bicarbonate of less than 15. Glycosuria and ketonuria. This can result from progressive deterioration with dehydration, electrolyte imbalance, acidosis, Kussmaul's respirations, and this can even cause death. Management consists of rapid assessment, adequate insulin to reduce the elevated blood glucose levels, fluids to overcome the dehydration, electrolyte replacement, especially the potassium. Insulin can chemically bind to the plastic tubing and inline filters of the IV tubing. This can actually then reduce the amount of medication reaching the systemic circulation. So an insulin mixture is then run through the tubing and you let it leave the tubing. So basically you're going to flush the tubing and let some of it just go into the sink. And that way you can saturate the insulin binding sites in the tubing before the infusion is started. And that way the child is actually getting the accurate dosage that you want them to get. Long-term complications. So microvascular complications can occur, neuropathy, nephropathy, and retinopathy. Microvascular disease may develop during the first 30 years of diabetes, and this can actually begin in the first 10 to 15 years after puberty when they've developed the type 1 diabetes. They may have renal involvement as evidenced by proteinuria, and they may also have clinically apparent retinopathy. Macrovascular diseases like strokes, cardiovascular disease, and peripheral artery disease can also occur. These typically develop 25 years after diabetes, and these are the predominant problems in patients with type 2 diabetes. So what are we going to do? Insulin therapy, glucose monitoring with a goal range of less than 126 milligrams per deciliter, monitoring the hemoglobin A1C, urine testing for ketones. Although it's not routinely done, typically this testing would be done and is helpful if somebody is ill. We would want to do that every 3 hours during an illness. And anytime the glucose level is 240 milligrams per deciliter or higher, we would want to do this even if an illness is not present. Nutrition, typically kids will be on a consistent carbohydrate diet. We do want to encourage exercise, but we need to balance the insulin and the diet with exercise. Teach the patient and the family how to manage hypoglycemic episodes. Illness management, we want to maintain a normal glycemic levels when the child is ill. Note that it's not uncommon when a child becomes ill for their blood sugar to be elevated. So they may need to check their blood sugar even more frequently when they are ill. Treat or test for urinary ketones and maintain hydration. And we already talked about diabetic ketoacidosis. So families need lots of education in terms of the illness, meal planning, insulin therapy. So will they be using subcutaneous injections, or will they be using an insulin pump? There are quite a few different types of insulin that can be used. We want to make sure that when they are using insulin, that they rotate the sites of injection. Remember, the abdomen is the fastest site, followed by the arms, and then the thighs and like lower back area. They're going to be doing glucose monitoring very frequently, typically before meals and at bedtime, and they may even be asked to do blood sugar once a week at 3 in the morning. You want to recognize and treat hypoglycemia and hyperglycemia, so parents need to be taught how to do that. They also need to be taught the management of minor illnesses. They need to have good record keeping, so they should have some kind of documentation, so they could use a journal. Now we have computers, so this is something that they could put in their computer, because that way when they go to the doctors, they can let them see what their blood sugars have been, the time they've been given the insulin, the amount of insulin that's been given, and this helps the doctor with their medical management. Hygiene, family support. Know that in terms of acute care, so when the child is initially diagnosed, typically insulin therapy is started after the initial rehydration bolus, because serum glucose levels will fall rapidly after volume expansion. So as soon as a child has established renal function, and they say that the child is voiding at least 25 milliliters an hour, note that, remember, in your younger children in general, we want to say at least a milliliter an hour per kilogram. And here, basically, insulin has been given. Vigorous potassium replacement needs to be implemented. So basically, we talked about this when we were going over GI with IV infusions. Anytime we're going to be giving potassium, you need to make sure that we've got adequate urine output. And because of the way the body acts when it is given insulin, it is super important that we replace the potassium, because we don't want them to become hypokalemic. So there are quite a few different types of insulin. There is a table in your textbook, so please make sure you go over these different types of insulin and note that their onset, their peak, and their duration. So we've got our rapid acting insulin. We've got our short, which is typically like your Humalog or Novolog, your Lispro types of insulin. Your short acting insulin, which is your regular insulin. So you'll see this as like your Humalog R. Your intermediate acting insulins, which is your Humulin N, or you might also see this called NPH, and then your long acting insulins. So this would be your Lantus or your like Glargine. So please make sure that you review that and you are familiar with the times of each of these. So the plasma glucose and hemoglobin A1C goals for children that have type 1 diabetes mellitus by age group. So for toddlers and preschoolers, so this is under 6 years of age, ideally, we want to have a hemoglobin A1C anywhere between, so including 7.5 to 8.5. Okay, so we want to have it more than or than equal to 7.5 and less than or equal to 8.5. And the reason is that because they are at high risk and they have vulnerability to hypoglycemia. So school age here, we want it less than 8%. Again, they have those risks of hypoglycemia, and relatively low risks can occur before puberty. And then risks of adolescents, this is 12 years old and young adults. Here we want them to have less than 7.5%. And the implications are the risks of hypoglycemia and then developmental and psychological issues. So age-specific care. Here, you want to look for support programs and summer camps. These can be very helpful for children with type 1 diabetes. And how can we delegate diabetic activities based on growth and development? So the preschooler, what can they do? You want to let them help. So let them help by getting the necessary supplies. Allow them to choose the finger or the location that's going to be poked with the needle. Allow them to choose foods to eat that are appropriate. So give them choices. They need to be able to identify a word that describes their feelings of hypoglycemia. And then you also want to teach them to help you by holding still for an injection. Note that I didn't say don't move. I said hold still. Remember, growth and developmentally, we want to tell them what we want them to do. School-age children, here they can check their blood sugars and urine for sugar and acetone. They can choose their injection sites according to the rotation schedule. They should be taught the signs and symptoms of hyper and hypoglycemia. They should be given hard candy for signs of hypoglycemia and know when to take that hard candy. They should be taught about their dietary needs. And then in the later school age, 10, 11, 12-ish, they should be able to prepare and administer their insulin, as well as checking their own blood sugar. Adolescents, they should be able to fully manage their disease and understand meal plans and snacks. And ideally, they will avoid risk-taking behaviors. Remember, it's very common for adolescents to have that feeling of invulnerability. So it is actually not uncommon to see adolescents come into the hospital in DKA because they want to be like their friends and they're not following their diet. So this is something that we really need to educate them on. Insulin, diet, and exercise must be balanced. If an increase in activity is not planned for, you want to give them a snack of 15 to 30 grams of a carbohydrate for 45 to 60 minutes of activity. If they're going to participate in a long sports practice and they know this in advance, they may take less insulin. These children also, and not just children, adults as well, should wear a medic alert bracelet at all times. Glucagon may be given subcutaneously for severe hypoglycemia. Place a child on their side as vomiting may occur. If they're not going to, if a meal is not scheduled soon after that, once they are awake and able to eat, you're going to want to give them some type of a snack. So maybe a little bit of a sandwich or half a sandwich and some milk because the glucagon only lasts roughly, 20 minutes-ish, and we don't want them to have their blood sugar fall again. Some signs and symptoms of hypoglycemia. These are due to an increased adrenergic nervous system activity, plus an increased secretion of the catecholamines. And these produce tremors, pallor, rapid heart rate, palpitations, and diaphoresis. They also may experience weakness, dizziness, headache, drowsiness, irritability, a loss of coordination, seizures, and coma are your more severe responses of hypoglycemia. All right. Lastly, we're going to talk about precocious puberty. And this is defined as a sexual development for age 9 in boys, so 9 years of age in boys, and then before age 7 in Caucasian girls, or before 6 years of age in African American girls. And this can be to a dysfunction of the hypothalamus, the AP, or the adrenal glands. The earliest signs in girls are breast bud development and pubic hair, and then the earliest signs in males is scrotal development. This occurs more frequently in girls. So there are 3 types. Central precocious puberty is 80%, so that's really going to be the one that I'm going to talk about. So in 50% of the cases, symptoms regress or stop advancing and no treatment is actually needed. Other options include monthly IM injections of luteinizing hormone, releasing hormone to regulate pituitary secretions, or subdermal implants of gonadotropin releasing hormone. The treatment of the specific cause, if it is known. The central variety can be treated with leuprolide acetate, which is also called Lupron or Depote. An alternative treatment is the gonadotropin releasing hormone analog, hystrulin implant. This is placed subcutaneously in the upper arm, and this can help to suppress LH and testosterone levels for 1 to 2 years. Know that GnRH agonists are associated with side effects such as headache, emotional lability, and vasodilation, causing hot flashes. So the desire is to slow the growth, the prepubertal growth to normal rates. So we want to monitor growth intermittently. Treatment is discontinued at the age at which normal pubertal changes would resume. We want the child to dress age appropriately and participate in activities that are age appropriate for the precocious child, the precocious puberty child. So just because they look older, you do not want to treat as if they are older. You want to treat them according to their chronological age. Sexual interest is not usually advanced beyond the child's chronological age. So please make sure the parents, they need to understand that the child's mental age is congruent with their chronological age. So please treat these children according to their chronological age in a developmentally appropriate way. And lastly, it is always important to support the family and the children who have precocious puberty, because this can be a little bit confusing. And please make sure that the teachers and the other people that are interacting with this child, that they are interacting with this child according to their developmental age, not how they look. That is it for today's content. Please make sure that you watch the presentations for the rest of this week's content. Thank you and have a good day.